everyone. Thank you for joining us today. Um, the time of cancer diagnosis can be extremely stressful for pretty much everyone. There are a lot of new terms that people are suddenly exposed to, plus a whole bunch of questions which you may not know when to ask, how to ask. Uh, there's people throwing questions at you and you don't know how to address those. So we thought we would discuss this topic as part of our World Cancer Day series, which we are doing with the support of Pfizer India. And because it's very important to focus and get the necessary questions answered during the consultation. So if you can prioritize on those questions, at least it helps you navigate the treatment better. And it is a given that, the more informed you are with good information, the better you will manage your treatment. So we are very privileged to have with us Dr. Vaibhav Choudhary and Dr. Karuna Kumar should also be joining us. We will be talking to them about the key questions that most patients should want answers to or may want answers to. Quick reminder, Patients Engage is an online platform for patients dealing with chronic diseases and their caregivers. It allows people to share their experiences as well as learn from each other and make better decisions and choices. Um, and also so we strongly believe that the better informed you are, the more empowered you are to manage your care. And we've always kept patients and survivors at the center of all of our conversations, all of our content, and largely driven by conversations which we have with patients, their family members as well. And based on that, we understand what the gaps are in terms of information needs and construct our sessions accordingly. So as I said, we are very privileged to have with us Dr. Vaibhav Choudhary, who is a consultant medical oncologist at Kokilaben, Dhirubhai Ambani Hospital in Mumbai. And we should soon be joined by Dr. Karuna Kumar, consultant hematologist, Yashoda Hospitals, Secunderabad. And I'm Aparna Mittal. I'm founder, Patients Engage. Uh, Quick reminder that this session is supported in public interest by Pfizer. The content is meant for information and awareness purpose only and is not a substitute for medical advice. So please consult your doctor for guidance on the information stated here. And the views expressed in this video are of the speakers, independent views, and may not be endorsed by either the sponsor Pfizer or the platform Patients Engage. And as I said, you can post. We are live currently on Facebook, YouTube, and on Zoom. So you can ask your questions on any of these, or otherwise you can email to us at editor@patientsengage.com and check out our website. So let me get started. Thank you, Dr. Vaibhav, for joining us today. Um, as I said, when patients go through the process of diagnosis, those few weeks are very, very stressful. There's a lot of information that they are suddenly exposed to. So let's start with the very basic, right? What is cancer, and what does it mean when people say this is the site of cancer?
Yeah, actually, I totally agree with you what you said that diagnosis of cancer actually is the most revolutionary event that can take place in any person's life. It's like it changes everything. Moment you hear those words that he or she or your relative or yourself have got cancer, so it's really a big deal because ultimately, what is human psychology? Psychology is what do you fear the most? Ultimately, we fear what we don't know.
Hmm.
Fear of unknown is the biggest fear. What we know thoroughly in and out, actually, the fear actually comes down, becomes manageable. We know that how to manage these things. So that is a very big thing. According for cancer, also this applies because there are so many myths. There are so many things surrounding this dogma that cancer. Initially, before 1970, we had no clue that why it happens, why what are the typical cell processes, why some patients do survive after surgery, why some don't survive, why does it come back? Thousands of questions. Now, sequentially, through years of research, it has been some 50, 60 years of very high productive research work which has gone into this field, armed with the sophisticated technology and the machines and whatever. Now we are able to map the whole genome. So, coming back to your question, what is cancer? Cancer, actually, in essence, is a genetic disease. It's a genetic defect. Genetic doesn't. We should not confuse this genetic word with hereditary.
Correct.
Once we utter the word genetic, people just think of Angelina Jolie and hereditary cancers and all that. That's only 5% of all the tumor burden.
Mm,
95%, though it is genetic, but it is somatic. Somatic means it's your own single cell, which is not, that defect is not brought in by from your mother or father or hereditary defect. That's the your cell which has become defective.
right.
Defective because of many stresses. We call it, in scientific terms, we call it as somatic mutations.
Mm,
Mutations is the word. So these mutations occur typically in a aging cell, uh, which actually becomes defective because of various stresses. Most common, as we know, is cigarette smoking, injury because of alcohol, any chronic inflammation. Many things are there. Like for breast cancer, the commonest culprit is estrogen exposure, high estrogen exposure, hormonal manipulations. Lot many things are there. Ultimately, what these risk factors, these are called risk factors for cancer.
right.
They actually hit your cell to such a level, at a genetic level, so that its nature changes. Human cells are actually designed to divide and then become stable.
Mm,
So here, that division process keeps on going in cancer
right.
cells. That's why
Right.
they are different from normal cells, and they don't know when to stop. So what happens there is they just keep on increasing in number, unregulated growth of cells, and they keep on. That's why they form a lump, and that's typically what you get in cancer, in solid tumors mostly, that you find the cancer with a diagnosis with a lump. So cancer, in essence, is a genetic disease caused by a mutation of a single cell or multiple cells as well, and it actually is an unregulated growth which escapes our immune mechanisms. This is very interesting. We should understand this, that as we have got immunity against bacteria, viruses, infections, God has also given us immunity against cancer. That's why
Right.
not everyone gets cancer. So whenever cancer directed immunity is weakened by whatever situation might be, and our cancer cells become smart enough to evade that immunity, then cancer comes to surface. So
Thank you.
this is what
Yeah.
it is at molecular level.
Right. Thank you. Thank you, Dr. Vaibhav. Welcome, Dr. Karuna Kumar. Thank you for joining us today. Um, just a reminder to our audience, as I introduced, Dr. Karuna is a consultant hematologist from Yashoda Hospitals in Secunderabad. Uh, Dr. Karuna Kumar, what is, can you explain what the concept of an organ or a site associated with cancer and how that affects the naming of the cancer, as well as, some cancers don't have names. So what does that mean?
Okay. So I'm a hematologist. So I deal exclusively with blood cancers. Okay. Blood cancers are other disorders where, non-cancerous blood disorders, like say simple
Right.
anemia, platelets, and all. So coming to your question, so depending on the organ involved, it's self-explanatory actually. So whichever organ involved, it's called with that name. Say lung, carcinoma lung, carcinoma pancreas. So similarly, blood cancers. Okay. These are called leukemias.
Mm,
Uh, there is nothing special about nomenclature of cancers. They are named accordingly with the organ involved. Okay, and so blood cancers, there are many hundred types actually. So there are a lot of differences between hematological cancers and solid organ cancers. The way they behave, the way they arise, the way they are treated, the impact on the patient, the prognosis. There are a lot of variations are there. There are acute leukemias which spread very fast in
right.
no time if not treated. So they are really fatal diseases. There are chronic leukemias which stay inside us. We don't even know that they exist inside us. So there are such chronic leukemias, and there are a few lymphomas, myelomas, and there are multiple aspects. And hope I answered your question. What is the second
Right.
part of your question?
So sometimes, okay, I'll come back to that question. Maybe Dr. Vaibhav, you can talk of, I know that the obvious ones are things like breast cancer means it's in the breast, lung cancer means it's in the lung, but there are certain cancers where it doesn't have the name of an organ, right? So for instance, like an Ewing sarcoma, etc. How does, why should, or how does somebody find out what it means,
Yeah, so coming to solid tumors, typically these are divided into two parts. One is carcinomas and sarcomas. Carcinomas, as Dr. Karuna also told you, that it is arises from a typical organ, and we are naming it accordingly.
Mm,
Sarcomas actually occur from the smooth muscle cells, mesenchymal cells, smooth muscle cells, or bone cells. So it can arise from any of the tissues and can undergo that differentiation. That differentiation is done after seeing under the microscope. So, for example, you are asked about Ewing sarcoma. Now, Ewing
right,
sarcoma is typically a defect of bone. Now, we have bones from our skull to our legs as well. So, there are some sites which actually are at high risk for developing this Ewing sarcoma. But it doesn't always follow that rule. It may arise at any place. In fact, it may even arise spinal cord compression as well by arising near vertebral region. It may metastasize. Though it might arise from a bone, but
mm,
then those cancer cells actually, when they become advanced and they flow in your blood,
right,
and then wherever they find a proper place to sit, they sit over there, mostly in lungs, liver, brain. So that is called metastasis. So that
right,
is secondary. That is
right,
not primary. So
right.
sarcomas actually where can occur from any of the mesenchymal tissue.
Okay, thank you. So one question that often happens during the diagnostic process, and I think both of you can answer the different cancers that are involved, is the fact that people get very, kind of frustrated with all the tests required, right? So it's not just one test which tells you, then you go to subsequent testing, etc. So I guess the one question that often comes up is, why am I being asked to do so many tests to diagnose the cancer? So Dr. Karuna, if you can talk
Yeah,
about the blood cancers, and then
yeah.
Dr. Vaibhav, you can talk of solid tumors.
So in fact, so many tests happen because so we don't suspect cancer or we miss the cancer most often. Okay, so to diagnose
Dr. Karuna, you've muted yourself. Go
so
ahead.
we need a simple blood test called complete blood picture. Okay, so most often this is enough to pick up a blood cancer,
Right.
because blood cancer is something which arises from white blood cells. So usually blood cancer patients, they have variations in their white cell count. So in few cases, obviously the counts will be so high, we can easily pick it up from a simple blood picture. Okay. Sometimes, the tricky cases are there. The blood cancer cells, they start developing in the marrow. So, but they may not enter the bloodstream yet. In such cases, there won't be cancer cells in the blood. There are such cases, but even in such cases, fluctuations in hemoglobin and platelets and the clinical features, so we may have to do a couple of maybe 3 tests to prove it's a blood cancer. Let's say CBP, and then a bone marrow examination,
You've
and
muted again.
especially that patient has to undergo through so many tests. It's only the clinical acumen of the doctor. No, most often, these cases are picked up seen by a physician in the remote areas. So usually these patients are considered to have some kind of infection, and they treat for infection. And also we need a good pathology laboratory to pick up these abnormal cells. Sometimes these are missed. They are read as just a lymphocytes or abnormal lymphocytes, which can be seen in a viral infections also.
Mm,
So these are the reasons why these are missed, and patients end up in undergoing a lot of blood tests, and then later they get the actual diagnosis.
right.
Actually, we need very few tests to confirm blood cancers. And about solid organ cancers, I think Dr. Vaibhav is here.
Yeah.
He's the right
Yeah,
person.
yeah. Yeah, so coming to your question, ma'am, that yeah, very valid question, that patient is frustrated with test and test. Tariq pe tariq, tariq pe tariq.
Mm.
Kind of.
And
So
it also
because
these days, it delays the start of the treatment,
I
which
know,
causes a lot of
I know.
anxiety.
I'll
Right.
explain. I'll explain. We are the biggest culprit for that. let me accept that. So the thing is, as I told you initially, that I mostly look into the complicated cases, stage 4, relapsed, refractory, and my forte is basically precision medicine and immunotherapy and targeted therapy. As science has advanced, we have found out that no two cancers are same. Like our fingerprints, they are different, right? So it's like that every individual is different, and every though breast cancer, for example, in two females, very unlikely they will be same. So ultimately, initially, when 100 years back, we used to diagnose breast cancer by seeing the lump or just putting a needle, FNAC. Right now, the days of FNAC are gone. Now, what we do is we do biopsy, which is we take out a piece of a tumor, and then it's not like that we want to hurt the patient more. That's why we are taking out a bigger piece. It's because in that bigger piece, what we get is the genetic information. In order to reach till the roots of the cancer, we need that much of information. And right now, tissue is the issue. That means that amount of information about the treatment of patients is actually generated from that biopsy only. So these tests, they are complicated tests, they are complex tests. Some of them actually are not even happening in India right now. What we are sending outside, like next-gen sequencing, they are very highly advanced tests. We are bringing it to India sequentially. Now, most of the work is being laid down. So as science is progressing, we have got more and more to offer. 100 years back, we had nothing to offer, just to take out and do a surgery for 100 patients of breast cancer. Out of them, 50 would survive, 50 would die. Now we are in a fight to save 90 or 95% of those 100. So for that increase in the survival, this is the price you have to pay basically. You have to just wait for 7 to 10 days. What helps patient in these times is a good counseling by your physician and proper education that why these tests are done. I typically handle my first counseling to any patient is at least 30 to 45 minutes because I answer all these questions. So the question you ask, why this test? Why genetic test? Why in breast cancer I want ER, PR, HER2, then HER2 by fish. So it's not like we are fond of doing tests. We also are. We are at more urgency to start your treatment, but we cannot give wrong treatment. Rather than saying wrong, inappropriate treatment or half-heartedly, we cannot just start. So we need a precise diagnosis for precision medicine because it has its own value. It translates into the responses and it increases the cure rates.
Right. Thank you. And I will come to Dr. Okay, let me continue with you, Dr. Vaibhav. So sometimes there are also these concept of cancer markers. So can you explain, cancer mutations and markers so that people understand? And then Dr. Karuna, you can tell us whether it's applicable in blood cancers as well.
Yeah, exactly. Cancer markers, actually, we know since many years now that by doing simple blood tests, we can find out that how the cancer cells are there and how much it has spread. Initially, to start with, we had some typical tumor markers, CEA, CA19.9, CA125 for ovarian cancer and colon cancer, lung cancer. We still use them, but with a word of caution, they are neither diagnostic nor very prognostic. We actually can diagnose relapse earlier, in a cured patient if those markers are rising. Now, as science is progressing, the days of these crude biomarkers are gone. They are not very specific also. So now what is happening is we are focusing our research more and more toward the circulating tumor cells, CTCs they are called, so that you get the DNA of the cancer in the blood. And now that is the future. That is where the whole focus is, to find out at a more molecular level. Because by the time your tumor markers rise like CEA, CA19.9, it's too late. Cancer is already spread. So just to preemptively diagnose it at an earlier stage, the attempts are made. This is still in trial mode. So tumor markers have their own role, but people actually take human body as mathematics, and then they say, okay, ye badh raha hai, ye kam ho raha hai, and all. They themselves are dictating terms by doing the test themselves. This is unsupervised testing is not at all justified, not advisable as well. It should be under advice of your doctors.
Right. And Dr. Karuna, is there similar?
Yeah.
Yeah.
So you see, as I told you, we need a few tests to diagnose cancers, right? So blood cancer is a very broad term. So there are three types actually: leukemias, lymphoma, and myeloma. Coming
Correct.
to leukemias, so you're looking at the blood picture and marrow, you can say the patient has an acute leukemia, but we need to know what type of leukemia it is. Very, very important in the way we treat the patient. The first step would be to exactly diagnose the type of blood cancer over there. Because treatment differs in each type of blood cancer. This is the first step. We use a special test called flow cytometry. So once we make a specific diagnosis, say acute myeloid leukemia or acute lymphoid leukemia, then we need to know how bad is the disease. Okay.
Right.
So we need to know how bad is the ALL, how bad is the AML. So say in solid organ cancers, we stage the disease depending on the spread of the cancer, right?
Right.
So blood cancers, often what we do is we classify or we prognosticate blood cancer by dividing it into low risk or high risk or intermediate risk. Okay. So this is done through a special test, where we look for specific mutations. So we study specific mutations in these cancers, and because there are certain mutations which lead to refractoriness of the disease, they don't respond properly. So they may need a higher form of therapy like stem cell transplant. So these mutation studies helps us to plan treatment properly.
Right.
To classify patients whether they require stem cell transplantation or not. So the second testing would be study of mutation studies, which information is definitely helpful for us to classify the disease into high risk and low risk. So this is how we use the information in blood cancers.
Right. Okay. Thank you. So coming to that, Dr. Karuna mentioned staging, and that was my next question. Dr. Vaibhav, can you explain what staging typically means? I know we are covering all solid tumors, so it may not be exact. And
I will tell you broadly what actually I tell all my patients as well. That ultimately, rather than the staging, first actually we want to go into the diagnosis, and diagnosis cannot be achieved without a biopsy and a histopathology report. Once my pathologist sees and tells that this is a cancer, this is the cancer cell, and then we go towards the staging. Staging typically is being done by whole body scans right now. It is much in vogue, much in fashion, like a whole body PET CT or CT scan of thorax and abdomen. So, very simple terms, when as a doctor I have to treat a patient, I have to divide or devise my intent of treatment. One is curative, that I will give a short treatment, 4 to 6 months of high dose everything, including surgery, chemo, radiation, and then I will cure the patient, try to cure the patient so that next 20, 30 years patient can live without any hassle. That is the intent of curative intent. Another intent is palliative, where I know that this is spread so much that there is no way on this earth to cure it completely. Then the plan B begins. Here we are focused more on quality of life. So just to divide between these two, so 1 to 3, stage 1 to 3 is in one bracket, that is curative, and stage 4 is in palliative. So that where actually we are focusing more and more to comfort the patient and to prolong the life as well. It's not like that, say stage 4 will live only 6 months, stage 4 will cannot live for 10 years. I have seen stage 4 living for 10 years, like because I have actually been privileged to be in Tata Memorial Hospital, All India Institute of Medical Sciences, even in my practice also since past 8 years. There are stage 4 patients who actually do respond, keep on responding for years together. So we never thought before starting that this patient will keep on living so long just because he's comfortable, his quality of life is good. So the staging broadly is, if the disease is confined to one organ, it is curable. It is, if it is very small, then stage 1. Then if it is a little bigger, stage 2. It is spread to the adjacent nodes, it is stage 3. When it goes from one organ to another, for example, a breast cancer goes from breast to lungs, then it is stage 4. So this is broadly what we want, and what before starting treatment. This has to be done before starting treatment, so that you are very clear in your intent, you are very clear in your communication to the patient. Because 1 to 3, we are curing. We will actually do a hard therapy on them, so that we want to batter the tumor, kill the tumor completely. 4, we want to comfort the patient. So we are more focusing on quality of life. And there comes the role of precision oncology, targeted therapy, doing less and less side effect to the patient, less and less harm to the patient, and more precision oncology. So stage 4 is important to diagnose, and then also the communication. Typically, stage 4, we are treating as a chronic disease.
Correct.
That's the right attitude for any patient. If some patients are listening, people are listening for layman, stage 4 cancer is not a death sentence in solid tumor anymore. Because we have got so many things, so many precision oncology things, targeted therapy, immunotherapy, that the idea should be it is like a chronic disease. Gradually, we are converting every stage 4 cancers into a chronic disease. Chronic disease means your hypertension, your diabetes, your chronic kidney disease, your chronic heart disease. All these diseases are also not curable. Diabetes is not curable, hypertension is not curable. They are manageable. But we are not so fussy about them because the tablet or the therapy to keep them in control doesn't got that much kind of side effect. Similar thing, if you can manage with cancer with targeted therapy or precision oncology, or rather say immunotherapy, so that the patient is comfortable, he keeps on going to his office, he keeps on living a normal life, then it's nothing to be afraid of.
Right. Thank you. We are talking to Dr. Vaibhav Choudhary and Dr. Karuna Kumar on some of the key questions and key terms you must understand at the time of diagnosis. While without going into specifics of molecules, etc., one question that we've got is stage different from grade? Because often for certain cancers, there's also a concept of grade. So if you can explain that, and Dr. Karuna, is that valid for blood cancers as well?
No. Grading is more of solid organ cancers.
Okay.
I think Dr. Vaibhav.
So I'll take it. Actually, the thing is, grade is histopathological. That's what my pathologist sees inside the microscope.
Right.
That it just gives an idea. It is kind of a prognosticating thing that this tumor will spread slowly, divide slowly, or divide very fast. There are some tumors like hematological. Dr. Karuna will tell you they double kind of in a 24 hours time. So grading actually is a pathologist diagnosis that high grade tumor will divide fast, will grow fast. So we are in a relative sense of emergency in starting the treatment, not emergency, urgency. And slow grade are slowly progressing, and then there you can actually have plan out your treatment, and it has therapeutic implications as well. It has prognostic, means how long patient will live. That is a question that every patient asks. For an elderly lady with a very low grade tumor, even if it's stage 4, we are not that much bothered. But for a young lady, even if it is stage 1 or stage 2, but it is showing high grade, so then it actually has more chances of coming back even after complete surgery. So these are the differences of grading. Staging is totally different, as I had covered earlier. That staging is radiological. We do a scan, and grading, our pathologist tells us the aggressiveness of the tumor, and staging is how far it has already spread.
Right. Thank you. So I know both of you have kind of, at least, Dr. Vaibhav, you've covered the typical cancer treatment options, but I think the important thing I want to focus on, so not so much is what are the options, but why is one person's cancer treatment different from the other? I think that's again a question that often gets confused, right? When two patients talk to each other, they'll say, mujhe chemo hua, tumko nahi hua, etc. So if you can, I know you've alluded to it, but if you can both stress on that factor, because that often causes a lot of confusion among patients. So Dr. Karuna, if you can talk about, why and how the treatment protocols for blood cancers tend to be different.
Yeah. See, if you take acute leukemia, say acute myeloid leukemia, acute lymphoid leukemia, more or less the protocols are the same. So we only change protocols depending on the fitness of the patient, maybe age. We look at comorbidities, how fit is the patient, whether the patient is going to tolerate the chemotherapy or not. Based on these inputs, we slightly change the regimen over there. But most often, the chemotherapy will be standard for all the diseases, and these are standard chemotherapies. They won't differ between patients other than these aspects. And whereas coming to lymphomas, again, the points we take into consideration are whether the patient, how symptomatic is the patient, and what is the age of the patient, comorbidities. Usually, most often in blood cancer, say leukemia, lymphoma, myeloma, take any kind of blood cancer, we change the regimen based on the fitness and the tolerability levels of the patient, and depending on the age. Right. But often the regimens are standard, and usually they don't differ. solid organ cancers, Dr. Vaibhav will take over.
Dr. Vaibhav, then you can. Yeah.
Solid or broad principles are the same as HEMAT, that there are device guidelines to treat a breast cancer patient, a lung cancer patient according to certain regimens. There are consensus guidelines. So we usually have to follow them. But as I told you, there is a lot of heterogeneity in the solid tumor domain. Like no two breast cancers are almost exactly same. Inside breast cancer, there are molecularly 10 different types of cancer. So all those 10 patients, or broadly, as you can see, we have found out ER, PR, estrogen receptor, progesterone receptor, and HER2 receptor. These are 3 receptors by which we divide the tumor classically into 4 categories, permutations and combinations. So all those 4, at least the treatment are absolutely different because we target different things. Based on the receptor status or the molecular profiling. So that is different. For lung cancer also, since this term precision medicine has come, stage 4 lung cancer, very rarely does 2-3 patients of the lung cancer receive the same treatment, because we go into the molecular level and we found out that here in some cancers that some driver mutation is different, and we have got a different drug for that. For some, there is some other mutation available. We have got a different drug for that. For some, there is no targetable mutation. For that, we have chemotherapy and some common form of immunotherapy as well. So that's why, due to the development and the recent advances in the solid tumor domain, where we have going more and more into personalized therapy, so that's why the protocols vary. So one size fits all. That concept is gone completely. So typically in our scientific literature also, we start our articles by writing breast cancer is not a single disease. It is a group. It's a group of 8 to 10 different diseases. They have to be treated differently. Sarcomas, as you mentioned, sarcomas, actually there are at least 67 to 68 types of different sarcomas. But broadly, there are consensus guidelines. But if you are lucky, you can find out some molecular target and stick to that target therapy so that the treatments are different. Another thing is personalization. That means personalizing the treatment, if what patient can actually afford, not only physically, in a non-resource constrained setting, in a where every patient is able to afford everything, because in India cost is also a constraint. True. So you have to fit in somehow. I have been trained in Tata Memorial Hospital. There we see all sorts of patients. Every patient, from rich to rich patient and to on poorest of the poor. So for our different OPDs, different patient, we have to customize the treatment for the patient depending upon his age, his comorbidities like diabetes, hypertension, heart disease, kidney disease, liver disease. With that, our drugs actually vary, our doses vary, our regimens vary, and in the end, to fit it into his budget. That also is a customization that in India, additionally, we have to look into it. So in India, the practice, because patient mostly pays out of their pocket. So you have to fit in that as well. That's why these changes are there. And it is up to the personal handling of your treating oncologist, how involved you are and how involved your oncologist is, how clear is your communication. Why am I getting a different therapy? This will always avoid the confusions.
Right. Thank you. And I think you both of you have mentioned the term refractory. Can you kind of explain that as well? What, Dr. Karuna, if you can talk about what is refractory?
So we say refractory when the disease is not responding to the first line treatment or whatever, even second line. So usually each cancers are, as I told you, there are different blood cancers, and each type of blood cancer we start with a standard regimens. So once they don't respond, so we call them refractory.
Okay.
So these are especially unique kind of cancers which are, which will really pose a trouble. And in fact, in blood cancers, these are very deadly diseases, often results in mortality.
Right. And one question, I think, Dr. Vaibhav, you broadly said that for curative, typically it's 4 to 6 months that you try and manage the treatment in. If increasingly there is cancer is almost like a chronic condition, so it's going on for 8 to 10 years. So how do you answer the question when patients ask is how long will my treatment last?
Depends. I have to be very honest with the patient, very clear with the patient, and ultimately, I cannot treat any patient without his or her consent. That is very, very, very clear. So you need to have a clear session with the patient. Not if it is not possible in the first visit, because a lot of apprehensions are there. You have to take in. We have our counselors as well for actually telling the patient, breaking the diagnosis. All those things are there, but in a relaxed environment, you need to sit with the patient, because ultimately, as a physician, as a oncologist, my honesty is 100% with my patient. I have to treat the patient. Patient has to take whatever effects, side effects, and whatever repercussions of the treatment is there, patient has to take. The
Right.
relatives, caregivers, however bothered they might be, they are not going to suffer chemotoxicity, right? The
Correct.
chemotoxicity has to be suffered by the patient. So I need to be very clear in my communication, what to expect, and what we are doing to avoid those side effects, and just to develop that attitude of fighting spirit against cancer, that yeah, things are difficult, but many people have got over it, and this is manageable. It is not incurable, it is not a death sentence, it is manageable. So with the right sort of attitude, right sort of communication, right sort of personalized therapy, and now actually we are living in a time we have got so many options to personalize. There are so many drugs available, not even chemo, even chemotherapy also. We have got wonderful drugs, neo drugs. Like chemotherapy is just one word for a layman. But for me, it's a whole world in itself. Because in chemotherapy, we have so many drugs, newer drugs, they have less side effects. You will be surprised to know, there are some chemotherapies, they don't even cause hair loss. Don't cause hair loss. So that is a notion that chemo, once you put chemotherapy, you will become
It's
bald
hairless.
100%. Sometimes patient actually come to me and they, sir, we are not having
दवाई
hair
असर
loss
नहीं
since the
कर रही है.
that is typical question that happens, that we come across such situations. So then you need a very, actually, there is no substitute of spending time with the patient and solving all these queries,
True.
because these are genuine queries.
Correct.
You have to put yourself in patient's place and then think. All these things are happening to you and no one is answering, and you are
Correct.
actually reading Google and getting gyan from lot many people. So this actually is not a proper thing. We have to be very transparent, very communicative with the patient. And here is the role of counselors as well. We do have counselors with us who actually explain everything in detail. I also spend, as I told you, my first session is at least 30 to 45 minutes with every patient by starting therapy.
Right. Right. Thank you. So coming to, I think both of you, at least especially you, Dr. Webb, have talked of that cancer patients can now continue to work while they're going through treatment. They can go out for social outings. Does that apply in blood cancers also, Dr. Karuna? Or, they have to be more careful?
Yeah. So definitely, blood cancers, as I told you, these blood cancers arise from white cells. So white cells are the ones which give us immunity, right? So they are the main backbone of immune system. So now they have become cancerous, and definitely the immune system is affected here badly. So that too, while on chemotherapy, usually their blood counts still go down further, and this creates a immunodeficiency state. So with blood cancer patients, they need to be careful. They need to follow, nowadays we just say follow all COVID precautions, because everybody knows what COVID precautions are. Hand hygiene, wear mask, and eat healthy cooked food, avoid crowds. So these are the precautions we always advise for blood cancer patients while they're on treatment. Even after completion of treatment for 3 to 6 months, still their immune system is not up to the mark. Sometimes we, especially post-transplant setting, we revaccinate patients. Even without transplant, also there are situations where we vaccinate patients, when they are especially at risk for certain infections. So there is a period where they are really susceptible to all these infections. There they have to follow all the special precautions. Once they cross the set period, then they are free. They can continue with their routine activities. Again, this differs depending on the type of blood cancer, yeah? The duration of treatment they take.
Right. Right. Thank you. And I think you addressed the question on hereditary versus, genetic diseases. But the one question that again comes up all the time, and I'm sure you've answered that question, is, why me? Or, is it my fault that I got cancer, right? So if you can also address that question, Dr. Weber.
Yeah, exactly. I would just like to ask my patient whenever this question does come, because as I told you, it's very difficult thing to digest that someone tells you got cancer. Why?
Correct.
Obviously, it's a phenomenon which happens, and that is perfectly understandable. As I told you earlier, also initially that what are we are afraid of? We are afraid of the things which we don't know.
Mm,
you can't uh, you can't just say that cancer cannot happen to me because I am following a healthy lifestyle. I am
mm,
not drinking. I'm not smoking. XYZ is smoking 60 cigars a day. He is not having cancer. Why
correct.
me? So all these things do come in, but ultimately, it is such a heterogeneous disease, and it's not like mathematics. Human body is made by God. It's not made by human beings. It is
Mm,
not equations which are going to solve. We obviously, with the research we are doing, we are trying to solve an unsolved puzzle, and to an extent, but ultimately, half of the cancers, the cause is still not known.
no. Mm,
And if someone asks me that what is the short way of avoiding cancer, like people ask about vaccines, people ask
mm,
about healthy lifestyle, all these things do contribute to a bit. But the only short way of avoiding any cancer is not to be born.
mm,
Right? Everyone who is born is at a risk of some or other part of cancer. And this
correct.
is not just out of my head. This is the data which is generated by SEER database in US basically. And 2011 they came out with this, and they said that average life expectancy around 70 to 80 years. In India, it is around 69, 70 years. So if an average male lives for 70 years and the cells start aging, then in those 70 years, he is supposed to get every 1 out of 3 females and 1 out of 2 males will get some cancer of some part of body. It is that rampant. But
Mm,
a lot of these cancers go unnoticed, like prostate cancer in elderly age group. That there a lot of autopsies actually show for 100 cause that they had cancer changes in the prostate. They don't
right.
die of cancer, right? It is just an aging process. It is just a process which has actually born out of the uncontrolled division and some damage to the cells. So there is no answer for this question, why me? It's ultimately what you can say, it's just luck. That's it.
Mm,
To put it plain and simple, you have to
true.
deal with it. You
True.
have to deal with it. There are many things like we didn't choose our parents where we will be born. We had no choice about that. We hardly nowadays we do have some choice about our life partner as well as similar with kids. So these are things which are actually you cannot choose it. You cannot. You have to. Everyone who is born is going to die someday. No one has lived for
Correct.
200 years. Right? Human body is made to last. Even all the organs like kidneys and all, they start decreasing their function after
Mm,
70 years.
right.
So then you are on support, right? So ultimately, there has to be some way. So that's why, rather than asking why me, the question should be how should I, right now I am here, how should I manage it? Is it manageable? So that is the right attitude that I like to develop in each and every one of my patients.
Right. Thank you. I know we can keep going on, and I'm
Yeah.
conscious of the fact that it's a long day for you guys, both doctors, and we
So
are
I'll add one more point before
sure,
ending.
sure,
So,
sure.
the points which Vaibhav discussed are very valid. And in fact, they are more valid in blood cancers. So
Mm,
Dr. Vaibhav said 50%, we don't know. But in blood cancers, 99%,
we don't know.
there's no cause at all, completely. And,
Right.
this counseling part is really difficult. And this journey is really difficult. And actually, we need to be like one of the motivation speakers. We should play
Mm,
that role also with the patient.
right.
That role
Right.
is very, very important. Often what I observed in my practice, once you are supportive, once you
Mm,
motivate them, once you make them understand what they are going through, most of the patients, they do well.
mm,
Often what I observe is the depression and the fear of cancer, which
right.
brings down the patient very fast than the cancer.
Mm,
This part is very, very important. There we play a very crucial role in handling these patients.
right.
If we play a part well, I think is the reasonably see, even however bad the cancer may be, however bad it may be, we can make patient life tolerable, and in a pleasing way we can make their lifestyle. It's
Mm,
possible. It's possible. This should be understood. Okay,
right.
right.
Right. Thank you. Thank you so much. I think it's important, as you both have highlighted, that it is important to answer these questions. It is important to handhold patients as they're going through this, and hopefully, and not just the doctors, but the whole support system. Thank you so much, Dr. Vaibhav and Dr. Karuna, for taking the time. As I said, we will always have lots of questions on these because it's a huge topic that we're trying to address. But I think we have addressed quite a few of the basic questions, and we do hope that the audience will find this useful. If you have any further questions, please do write into us and we will be happy to take that further. We've also put up a glossary on our website, so you can, kind of look that up as well. And once again, thank you, Dr. Vaibhav and Dr. Karuna Kumar, for joining us today and addressing so many of these questions, and to remind patients that the better informed they are, the better they will be able to manage their condition. As well as the fact that cancer is not a death sentence. There are treatment options. There are, do discuss your intent with the doctor and have a meaningful conversation with the physicians. So thank you so much, and thank you to Pfizer for supporting this as well. Let me stop the